In this 67-year-old woman with a history of recurrent urinary tract infections, not responding to several courses of antibiotic treatment, cystoscopy under light general anesthesia with the 17.5 French female cystoscope or urethroscope surveys the lesions of Trigonitis. The trigon is covered by inflammation, pus pockets, bullous lesions, and small incrustations that are frequently found in these chronically infected women. The ureteric orifices are identified. A fine-tip Bugbee electrode is introduced to cauterize the lesions over the trigon. The cautery is set on 20 to limit the depth of penetration. The edges of the trigonal surface to be cauterized are marked starting from the ureteric orifice down to the bladder neck area and then across the bladder neck area without involving the urethra to avoid a bladder neck contracture. Next, the interureteric ridge is cauterized by starting medially to the ureteric orifice and traveling to the other side. Finally, the whole infected trigonal surface, circumscribed by these margins, can be safely cauterized. The procedure ends when all lesions have been cauterized. The white, fluffy trigonal shedding can be irrigated out. The cauterized trigon will take 6 months to heal completely and be replaced by a nice, shiny, rosy surface with no residual infection sites. We recently reported on the long-term efficacy of this procedure in a cohort of women treated between 2004 and 2008 who had a mean follow-up of 4 years. In this IRB-approved study, fulguration of Trigonitis was performed on an outpatient basis in non-neurogenic women with recurrent urinary tract infections who had at least 1 year follow-up and who underwent an office cystoscopy at 6 months after fulguration to verify trigonal healing. The primary outcome for success was a completely healed trigon with no evidence of any residual Trigonitis. The secondary outcome included repeat episodes of urinary tract infections documented by either urine cultures or antibiotic courses prescribed for lower urinary tract symptoms suggestive of a urinary tract infection. 3/4 of these women with proven resolved Trigonitis had very few infections over the ensuing years, whereas those with residual areas of Trigonitis had more frequent infections than the success group, although less so than at baseline before the Trigonitis fulguration. This simple procedure can assist in the challenging management of recurrent urinary tract infections in women with extensive Trigonitis by eradicating these presumed sites of bacterial persistence in the bladder wall.